It's a half an hour session, sir. So we'll try to wind it up within 4 with the question answers.
Sure.
Yeah.
We're starting?
Yes, sir. Just a minute, sir. We are live, sir. With all your due permission, we are beginning with the session for today.
Yeah.
Good afternoon, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our eminent stalwart who is present here with us today. Well, he is none other than the very renowned diabetologist, Professor Dr. L. Srinivasa Murthy, sir. Sir is MBBS, MD in Internal Medicine, FRC from Edinburgh, FRCP from Glasgow, FRCP London, FACP USA, FICP, FRSSDI, PDCR, ACCR, Senior Consultant and Diabetologist at Lifecare Hospital and Research Center, Bangalore. I would like to welcome Sir at our forum, and it's a great pleasure and honor to introduce him at our forum. With this, we will move on to today's topic, which is management of diabetes. Before moving on to today's session, let us have a brief look on what the topic says. This is going to be an informative session focused on the effective management of diabetes. Diabetes is a chronic condition that affects millions of people globally, and understanding how to manage it is crucial for a healthy and fulfilling life. This offers valuable insights into the various aspects of diabetes management, empowering individuals with the knowledge and tools needed to take control of their health. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his enriching talk to begin with his wonderful experience. Sir, over to you.
Thank you. Thank you and good afternoon. I know there is a high voltage match going on, so many of us are still practicing and trying to treat our patients. And today's topic of the day would be the management, where I'm going to stress upon few points which in routine clinical practice can be helpful for us. To begin with, we know the cardiovascular, renal, and metabolic conditions are the disease burden globally, and the common soil hypothesis for all these would be our diabetes and hypertension. And we know 50% of patients who are diagnosed with heart failure die just in the span of 5 years. And the global prevalence of CKD is about 11%. And CKD is asymptomatic in early stages, which most of us tend to neglect or the overlook the symptoms what the patients would probably tell us, like repeating pedal edema, ankle edema. And definitely this low awareness will lead on to the complications to our patients. And the diabetes prevalence is rising across regions. And there are about more than 530 million people with diabetes as of now, and more than 60 million people with heart failure, and about 850 million with CKD. Look at that, is the major segment where there is a great need, and this unmet need in all these diseases is very, very important. This is the latest ICMR INDEB 17 study, which was published in this May 2023 in Lancet. You can see very clearly the rise in abdominal obesity. The pre-diabetes are more than diabetics, and that's something to be worried about, because this is where our primary prevention, being aware and trying to implement lifestyle modification to our physicians, clinicians, and definitely patients can be prevented getting converted into diabetics. This just to show the prevalence of cardiometabolic risk factors among the study population in this ICMR INDEB study, where diabetes, pre-diabetes, hypertension, all the risk factors you can see, including the generalized obesity, where the BMI was taken above 25 as a cutoff, and you can see the urban and rural cutoff. That's the most important point, what I want you people to look at. And that is where all the metabolic non-communicable diseases, what we call NCDs, except pre-diabetes, are more in urban than in rural. And the most worrying point, the pre-diabetes is more in the rural point also. So the number of people who are on target of less than 7, the ADA recommendation says when you're managing diabetes, you need to bring down below 7%. And that, look at the proportion of people who are achieving this in spite of the medications, lifestyle, health habits among individuals. And this is true across the globe. Just to show you, in this study called Discover Study, more than half of the people worldwide who are undergoing treatment intensification had HbA1c of more than 8%. That is something to be worried about. You can see this color, and this is where you can see the most of the colors are there, which is whether it's Africa, the America, the Europe, it is all same where the control is poor. And the onus is on treating physicians where we do not cater the population properly regarding the control or the betterment for our patients. So we know we often fail to maintain the glycemic target with a single drug. And this is just to show in the UK PDS study, which is about 20 years long study followed up now, the first 10 and the next 10. And you can see very clearly the conventional therapy and the individual drugs as they fail, as they progress. So treatment intensification, that is where the management question comes up, that you need to use the second, third, fourth drug at the earliest, do not have the clinical inertia of uptitrating or adding on a drug. So definitely maintaining our patients on a single drug monotherapy would be difficult. And you can very clearly see in this slide where at the end of 3 years, 6 years, and 9 years, who are people who are adequately controlled, how they lose their efficacy over a period of time. And this is again seen in the UKpedia sub-study called 49. And this is what happens when there is an early and sustained proactive glycemic control, which can reduce the risk of complications. And this is the 20 and 30-year follow-up of your UKPDS. And this is where it showed clearly. I'm sure this slide, all of you would have seen a number of times, where there is a reduction of complications with 1% of A1C. You can see the 12% any diabetes endpoint, microvascular disease by 25%, MI by 16%. This is what it showed. And the best part, even at the end of 30 years, look at those numbers are not much changed. So the legacy effect, what we call, is being definitely there, continued beyond the initial 10, 20, and now it is still going on for the 30 years also. And this is what the STENO2 trial showed, that the macrovascular benefit first time compared to the other benefits which were shown, that the intensive multifactorial intervention will result in definitely advantages with the macrovascular reduction also. Now, why do the patients fail to sustain their control with only the monotherapy? That's because of this. I'm sure all of you are aware, the diabetes is a progressive disease where the beta cell starts declining and the reduced insulin production, insulin resistance increases, increasing hepatic output. And that is where, at the end of the day, they have the development of microvascular and macrovascular complications over a period of time. And we know that by the time somebody is diagnosed, it's minimum of 5 years where the IGT would have set in. And that is where the pre-diabetes, where we need to tackle and take care of our patients, very, very important. So by the time at the end of the diagnosis, somebody is diagnosed, 50% of the beta cell failure are assured. That is where we need to be careful about tackling the diabetes very early in their lifestyle. Now, what are the basic defects? It is at the level of pancreas, we know, where there is an increased glucagon and reduced insulin secretion. At the level of liver, increased hepatic glucose output. Kidneys, there is a increased glucose reabsorption, of course, in the initial stages, then later on it reverses. At the adipose tissues, there is an increased lipolysis and decreased peripheral uptake, peripheral utilization of glucose, as we say. And there is at the neurotransmitter level, there is a dysfunction at the gut. Now, the incretin effect, as we know, has gained such a momentum in our treatment, and that is called the Omnius octate by difranzole. So, when you are treating a patient, you need to address the multiple defects in a combination approach. That is what we are talking about, the management of diabetes. Of course, to worsen, there is a sequential treatment approach is often compounded by substantial clinical inertia of timely initiation. This is typically what we do. You can show in this cartoon in the bottom, where after the first OAD started, the second OAD takes about 3 years, and the third OAD takes about the whooping 7 years, and another 7 years to add on insulin. So imagine to go on to insulin from the day they diagnosed, they would have taken 15 years, where a lot of complications, because on an average, we say 10 years is the time period where each patient would have got some kind of complications. And this is where we spend most of our time losing in treatment because we go with the stepwise treatment. So the bad legacy effect sets in, and the good legacy effect, what we tend to claim through our Wikipedia study, what we showed just earlier slides, and this is where it gets negated because of the sequential therapy, which we tend to waste time, and that is where the dysglycemic legacy starts in, not the good glycemic legacy. So if somebody's patients with the A1C more than 7%, not receiving the intensive therapy within 1 year, at the end of 5 years, they can have a risk of MI by 67%, stroke by 50%, heart failure by 64%, and composite CV endpoint by 62%. This is going to be the complications of not intensifying within 1 year when you see somebody's A1C is above 7 years. So all this more than 50-60% risk of MI, stroke, etc., is the onus is completely on the treating physician because of his inertia not to uptitrate the treatment. So this is what was our classical therapy: OAD monotherapy, then uptitrate, combine, then add a basal insulin, then basal plus, then multi-daily, and then GLP-1s, where eventually 15-18 years of time, precious time, is lost. And that is what we are trying to now change the management of diabetes. And most important, the incremental cost, what the patients incur, is something you need to remember. Now, this evidence to manage with multiple drugs, this was one of the trials with vildagliptin and metformin combination, which clearly showed us the VERIFY trial, where the cumulative probability of initial treatment failure will be neutralized. And the VERIFY strengths, this trial was, it was all done in a newly diagnosed diabetics. It was a diverse, geographically distributed, multi-ethnic population, long study duration, well tolerated with no unexpected or new safety findings. Alarms were not, there were no safety signals, and reproducibility in glycemic durability in an international heterogenic population was seen. And of course, the key findings were early combination treatment reduced the risk of time to initial treatment failure by 50% when you compare vis-a-vis with monotherapy. The median time to failure was 3 years in the initial monotherapy strategy compared to over 5 years in the early combination strategy. When all patients were receiving combination therapy, the risk for time to second treatment failure was reduced by 26%. And both these approaches were safe and well tolerated. So this is another slide which I showed you, the DISCOVER study, global study, where the impact of early or late intensification of glucose lowering therapy was studied over 36 months. And you can see the blue one is the early intensification, the yellow one is the late intensification. And you can see the proportion of patients achieving the A1C of less than 7% were more in the early intensification. And what are the learnings from this global trial? 3 years follow-up was there, about 3,000 plus patients, that early diagnosis and timely intensification of glucose lowering treatment is important for achieving long-term glycemic control, thereby improving the clinical outcomes. That is what was the result. So this is enough evidences to show that the early combination therapy versus monotherapy, definitely the combination therapy scores over the monotherapy. Now, this is the 2022 ADA EASD consensus report, which recommends that the combination therapy should be tailored to individual patients. So they've been advocating the combination therapy, that they have several potential advantages like increased durability of the glycemic effect, addressing therapeutic inertia, simultaneously targeting the various pathophysiology, the Omnis octet, what we're talking about. Simultaneously, they target the multiple pathophysiological defects in the development of diabetes, impact on medication burden, medication taking behavior, and treatment persistence. And of course, the complementary clinical benefits where, for example, when you combine with the GLP-1 or SGLT2, you can have the glycemic control, the weight control, the CV risk profiles, and all these cardiorenal benefits. And when do you initiate? This is basically we're talking today, the topic was the management of diabetes. So when to initiate a combination therapy and what are the latest guidelines tell about this early combination therapy is the early combination therapy can be considered in patients with HbA1c levels more than 1.5 to 2% above their respective target. This is the ADA 2023. That means somebody's target you fix, say, a 35-year-old guy comes, you fix less than 7%, and his HbA1c is 8.5 to 9, then you can initiate early combination therapy. Similarly, the AACE, that is ACE, and talks about the HbA1c more than 7.5%, you can start off, or the entry HbA1c is more than 9% or 1.5% above the target, you should consider double or triple therapy. They have been even gone to the extent of saying triple therapy, and consider initiating combination therapy if A1C is about. This is our own RSSDI 2022, which we are part of, and clearly talks about A1C more than 1.5% above the target, you need to put them on the combination therapy. Again, showing advantages of fixed dose therapy versus co-administered dual therapy. So co-administered dual, that means individually, whereas FDC. FDCs always have advantages of synergism, pill burden reduction, cost benefit in many occasions, and that is where the FDC score over others. This is one of the examples where literally when you combine SGLT2 DPP4s along with the metformin, it can tackle all the multiple 8 defects, which we're talking about, the Omnis Octet, defranzose, Omnis Octet, can be taken care with this aspect. So early combination therapy in the management of diabetes can ensure early and better glycemic control, which can be durable with less risk of hypoglycemia, no weight gain. In fact, there can be weight loss, and therefore improves the patient's adherence to treatment, possibly reducing clinical inertia, offering more opportunities to address individual patients' needs. And the benefits of combination therapy, again, in the management of diabetes, we should remember that addressing the underlying pathophysiological defects, complementary mechanism of action, better efficacy, and enhanced glycemic control, and FDC helps to achieve this additional benefit of compliance and adherence. So to conclude, about 67% of diabetic patients in India remain above their target A1C level. That means more than 3/4 of the patients do not achieve the target level of A1C for their level individually, of course. A delayed intensification can significantly increase the risk of myocardial infarction, stroke in these already high-risk diabetic patients. And studies have clearly shown that the intensive glycemic control reduces the risk of both micro and macrovascular complications. And all the guidelines definitely advocate the combination therapy of A1C, combination therapy of drugs when the A1C is beyond 1.5% above the glycemic target for that individual. And combination therapy not only acts on multiple pathophysiological defects, but also provides a good A1C reduction to help the glycemic goals without increasing the pill burden. So the early robust lowering of A1C can happen. It is more likely to reach targets for the control, and it can avoid or delay at least the clinical inertia and potential to use less than maximal doses of individual agents to minimize side effects. So thank you very much for patient hearing. Any questions, suggestions, I'll be very happy to take up. Thanks again for joining on a weekend, and now let's move on to the Q&A.
Yeah, thank you so much, sir, for your enriching talk that you have delivered upon this topic with such a wonderful presentation that you have shared with us today on our live platform. Thank you so much for that. We have received few questions, sir, from the participants. I would like to put across those questions to you. Yeah. The first question is, what is your opinion in quality improvement intervention for diabetes management?
Oh, the question is a little bit vague because the quality of life is a measurement which is subjective. The quality of life, what we talk about is, for example, somebody with a busy schedule cannot give enough time to his management, then shifting that patient from the busy schedule, neglecting his health, that itself becomes the quality of life management in that patient. Most of the times, the quality of life, what we see is through complications. Because, for example, the neuropathy, which is one of the most common complications we see, And because of neuropathy, the lack of sleep and the vicious cycle where it goes on with the disturbed circadian rhythm and giving rise to a lot of complications with our patients. I think that's the most important point. And the quality of life questionnaires are available, which are very, very easy to be answered in the waiting area. Many of us, I mean, I don't implement to all the diabetics, but definitely some patients where the sugars are very much fluctuating, not getting well controlled in spite of 3-4 drugs and maybe a basal insulin, you need to figure out that this patient may not have a proper support from the family, may not have support from himself, that is in the form of lifestyle. So this is where the quality of life comes into picture.
Thank you so much, sir. Thank you for answering that question. We will move to the next question that we have received. And the question is, what are the new developments and concepts in the diagnosis and management of diabetes insipidus?
Okay, diabetes insipidus is not the topic of discussion today.
Yeah.
And that is an entirely different one. Maybe offline I can answer. We can take this doctor's number. We will deviate the subject today because it's a management of diabetes mellitus what we talk. I mean, diabetes, unless otherwise proved, it's DM. It's not diabetes insipidus.
Thank you so much, sir. We will move to the next question. And the next question is, what is the perioperative management of cranial diabetes insipidus? Again, it's a question related to insipidus in a patient requiring a tracheostomy.
Okay, I think we will discuss this off the record, not as a part of this discussion.
Sure. We will move to the next question. And the next question is, what is the association between central diabetes insipidus and type 2 diabetes mellitus?
Okay, somebody is talking only about diabetes insipidus.
Right.
Yeah, I think we should have mentioned diabetes mellitus probably in the title because we have told management of diabetes alone. So it is not going to be insipidus.
Yeah. So what we can do is, sir, we can definitely have another session on this particular topic of diabetes insipidus where we can take up these questions.
Definitely.
So I would like to thank all our viewers and to wait till the time we come up with diabetes insipidus topic with sir, according to his time preference and his convenience. So till that time, I would like to thank all the viewers for their ardent participation that they have shown and for their patient listening throughout the session. And with this, I would like to thank you, sir, for taking out your valuable time and for being here at our platform and for delivering such an enriching talk to us. Thank you so much for your efforts, sir. And we would be waiting for your time preferences so that we can take the diabetes insipidus topic from you itself.
Definitely.
Thank you so much, sir. With this, we are concluding the session here for today.
Thank you. Bye.
Bye, sir.